The main aim of the project was to improve annual health checks for patients with learning disabilities. The project aim came from my background work that I do with in the London side as running the STOP clinics. So every time we review patients, we ask them, have you had your annual health check done? And this annual health check is a commission service done by primary care in the GP practices. So every patient who's on the learning disability register is entitled to have this check done. And this should involve a holistic review of physical health, mental health, emotional health and well-being. And although we asked them, have you had it done, and it was always a yes or a no, we never really knew what the full quality of it was and what the outcomes came from it, and if the appropriate referrals were made from that. So the uptake of them is good for us across now. We are above target at 88%, but obviously, like I mentioned before, it's really important to know what the quality is like. So in order to get that baseline data, myself and one of my colleagues ran an audit across 2 GP practices in Redbridge, and we wanted to focus obviously on the medication review side of it, and what we found was that results showed no regular reviews of medication, no follow-ups from blood tests, and no action plan follow-ups either. So the main aim of the QI project was to implement a structured medication review template within this annual health check within the GP practices, so that the clinician would then be guided to complete a thorough medication review when they saw each patient. So thanks to Stephen O'Connor, who kindly met with me when I was doing the QI facilitator course, because I had no idea how I would show this qualitative data that I had on a run chart, and obviously we need run charts in the course. So he helped me to see how can I plot on a graph how many elements of a normal structured medication review were happening before the change idea took place. And as you can see, it was never more than 2. But once that structured medication review was then implemented within the template, all 8 elements were always completed because the clinician was always guided what to ask, what to check for, and make sure everything was included. So the main successes of the project, and the personal success for me, which is what I wanted from the beginning, was for each patient to leave these checks having a good understanding of medication, why they take medication, what each medication they take is for, and having the ownership, the management of knowing what choices they can make regarding their medication. And a really good thing that came from it was the collaborative working across primary and secondary care, which with us in the learning disability team doesn't really happen as much as it could. So it's just really promoting that, talking to each other. Obviously we use different systems, but we're all focusing on the patient's care, and we have different elements to their care, but we're not talking to each other about it. So having that more transparent relationship and saying, we did this today, we did that today, picking up the phone and talking to them or emailing them, just promoting that a little bit more. Because when I went into practices and saw how the annual health checks were completed, I saw that they had no real way of them telling us what had happened, but me just providing an email address or phone number really helped with that. And a big thing that's come from this is a training element. So although my plan originally was just to implement a structured medication review within the check, the GPs were like, can you actually come in and help our clinicians to do them? So I sit with PCN pharmacists and I sit with registrars, and we do them together. They watch me do them and then I watch them do them, and it's really just acknowledging the reasonable adjustments that need to be made when you're looking after patients who have learning disabilities, adjusting yourself, adjusting your meeting time, adjusting your room, whatever it is, but making sure that that patient feels comfortable, because if you don't have that in the first place, you can't really do a good review at all. Challenges of the project was making all the PCNs come on board with it. So I was lucky enough to have the GP who worked with me on this project as the clinical lead for learning disabilities for primary care, so she was more than happy to help me. But getting other GPs across other PCNs to take the time to get their practices to come on board with it, and that's still a work in progress. And also finding time in clinicians' caseload is obviously a big challenge, so just trying to emphasise the importance of why we need to get it done, and then allowing them to make that time is also a bit difficult, but we'll get there in the end when I keep nagging them. I also have another role as part of this role. I work with the personalised care team for NHS England, and I do that half a day a week. And that has really helped me to learn about different personalised care enablers, such as shared decision making and social prescribing. So I got to know the social prescriber within the practices, and I really used their expertise to then refer patients onto them after they've had an annual health check done. And that's something we're still working on, because a lot of my colleagues are still unaware of what social prescribing is and how it can really help in that patient's care as well. The next steps are going to be to ensure the SMR template is implemented across all practices in the Louth boroughs. That's still happening, and then once this happens, fingers crossed it will quite soon, we want to replicate this across the whole of North East London. So I will work with my colleagues in our neighbouring Trust Health. I have my counterpart there who's also a learning disability pharmacist, and together we can make that happen across the whole of North East London. And also from this project, we can talk about how it can be replicated across other groups like the CMHCs.